you can go.
Good morning, everybody, and welcome to the October Vale of York CCG governing body meeting. My name is Nigel Wells. I'm the clinical chair of the Vale of York CCG, and it's a pleasure to be with you today. There will be a couple of people who are running late who will join the meeting as this goes forward. There are a couple of apologies, and I'm just looking on my screen to say that Phil Goatley, Julie Hastings and Stephanie Porter are unable to be with us today. And there are no questions actually for the from the public today, so we'll be able to get straight on with our agenda in a minute. Just to say that declarations of interest, and if there's anything that outstanding on that we have to update, please let me know and bring anything to my attention as we go forward. Okay. So that brings us straight on into item number 3. So this is the patient story. I'm going to hand over to Michelle Carrington, Executive Director of Quality and Nursing, to lead this bit.
Thanks, Nigel. So I'm hoping that you'll have clicked on the videos that came with the agenda, because that really sort of brings this story to life rather than me talking you through it. And it's the story that we shared at the annual general meeting a couple of weeks ago as well. It tells the story of Martin Bissell, who lives in Selby and has been on the end of real benefit of a new service in collaboration with a number of agencies, including our primary care colleagues, and the strength of care coordination, really. And it took a population health management approach to healthier lives. And he received a letter inviting him to take part in this. And he knew, since he took redundancy from a really stressful job, that he had become quite immobile, really, in terms of not choosing to do exercise and take care of himself. And he just needed a nudge, that was his words, to get going with something different. And it started with a phone call, which he found hugely helpful. And he didn't think that he would. And he was on the phone about 2 hours with the care coordinator, looking at different ways that he could improve his lifestyle. And then he took part in a 20-week programme. And he was really inspired by that. What's really important is this was not purely medical intervention. Nobody asked for more GP appointments and nobody asked for more medication. And what he's seen is that he's lost 2 stone in weight so far. And that, in his words, he said he probably had 2 years to live and it saved his life. So I think that's really it in a nutshell, really. And it's obviously helping more than just Martin. And it's a really fantastic way of looking very differently at helping people who live in our communities and the strength of community support and care coordination, which is a hugely valuable resource to us all. And we've heard at this governing body before about care coordination in different things, such as dementia and cancer care. So that was just another story of Selby and what they're doing to help people that live there.
Great, thanks, Michelle. And if people haven't been able to click on those links or seen that who are watching, I would please ask you to do that. Give a bit of your time to have a look at that, because it's a really powerful story around that and about what we can do to get into prevention and proactive care. I don't know whether any colleagues have got anything to add to that before we move on.
Chair, I just thought that I mean, it was really powerful, and it was really good to see you know, what actually works on the ground. And I know this is a dreadful thing to say, but it actually struck me that it made a lot more sense about the NHS than some of the stuff I've read from the ICS about we're going to do this and we're going to do that and these are our values and whatever. It's just lists and lists. But that, I thought, should be watched by Stephen Eames and others, and maybe get them to refocus a bit on the health of our patients. I thought it was powerful.
Yeah, thanks, David. But what it talks to is understanding your communities, isn't it? And noting and understanding your communities. And I'm sure clinical colleagues on the call will understand that. And I think that's what we've got to make sure as we transition through to integrated care systems is that the local emphasis and understanding your community shines through and must be preserved, or else we will have lost anything that we're sort of building on that. Yeah. Okay. Thanks very much. Thanks, Michelle, for sharing that, and hopefully people can have a look at those if they haven't had a look at it. So that just takes me on to the more formal bit of the meeting, which is the minutes of the meeting that were held on the 1st of July, and hopefully I can sign those off and approve those if nobody's got any problems with those. And if we look, therefore, at the matters arising, which is on page 17, I think all of those are ongoing. Maybe the only one that I can see we maybe need to look at would be the feedback session to be arranged for clinical leads for care homes. But it might be that Michelle wants to pick that up in your presentation, or whether you wanted to say anything about it now.
What I was going to say was that we're thinking that it would make a good PLT session really to start with, because the final report is pretty much done. It's just out for factual accuracy into what happened at Lake and Orchard Care Home last August, when that care home needed to be closed during COVID, and what some of the lessons were. And I think that if we could hang some of the improvement and conversation on that report, that would be better. So that's what we're thinking of in terms of, we will bring this report to private session of governing body, and then we would use it for a PLT session.
Great, thanks very much. So maybe what we would do is put that action as completed, with the knowledge that it does come to a PLT session. I'll keep an eye out for that. Absolutely, that's brilliant. Thanks, Michelle, for that. Okay, so that neatly brings us on to item number 6. So that's over to Phil Metum for the Accountable Officer update. Over to you, Phil.
Thank you, Nigel. Good morning, all. Good morning to those of you watching this live stream. My report, as usual, will start with the financial position, and we'll hear more from Simon Bell about this as we work through the meeting. But as we've been able to report at previous governing bodies in this financial year, we've got a broadly positive position where we finished the first half of the year, which we call H1 in NHS management speak. As a statutory body, the CCG managed to achieve that position with support from other parts of the NHS system, which I think tells us two things. The pressure upon the CCG's financial position continues in the same way that we've seen in previous years, but it also tells us that we're now working in a healthcare system where other organisations are prepared to help those that are feeling a financial strain. That has all the hallmarks and characteristics of what we hope to see as we move towards integrated care systems. So that's really positive for us in that respect. Two aspects to the financial position that you'll probably be familiar with that are outside of our normal core funding. So just to remind everybody, there's the hospital discharge funding, which has been relatively successful, and we understand is going to be continued for the remainder of this year, and resources to support the recovery of elective waiting lists and the backlog. The way that was designed nationally is being reviewed and revised, and so that will work in a slightly different way as we move into the next part of this year. So we'll continue to keep that under review with David Booker chairing the Finance Committee for us. The planning for the second half of the year, which we're calling H2, is in early stages. The timing of governing body will probably not fit with us being able to take an effective oversight of that. So what we will do is we'll make sure that the Finance and Performance Committee is able to do that on behalf of this governing body, and will escalate any issues if and as required. So moving on from the financial position and thinking about the healthcare system, the position is broadly as we've reported previously. So primary care continues to see very high levels of demand for both face-to-face and virtual appointments. The acute sector, if we look at York Hospital ED, attendances are higher than they have been previously. It's creating a new norm in terms of the average attendances that we see, and there continues to be a demand that we've not seen before prior to pandemic for mental health support across all age ranges. The workforce fragility that we have been seeing over recent months continues across all of those sectors, and particularly in the social care sector as well. So the overall position is there's a significant demand for all of our services. Our workforce continues to be one of our main areas of focus. And as we go into this second half of the year, it looks like it's going to be particularly difficult as we enter the winter period, and we continue to be asked at a national level to do everything that we can to reduce waiting lists and clear the backlog. So that is part of our focus at the moment, but in the context of all of those demands that I just described and pressures on workforce, it will be a difficult period. Moving away from the services and just thinking about the CCG as a statutory body, we are now starting to take forward the due diligence exercise that we will be responsible for that relates to the close down of the CCG. I would ask this governing body to rely upon the executive committee supported by the deputies to lead that work, and we will provide an update to the next governing body on how that is progressing. Also, the executive committee will lead and take an overview of the transfer of our staff to the ICS, and those processes will be starting to move in some form between this governing body and the next time that we meet. So again, there will be an update for governing body about that. But the message for our staff continues to be that there is a guarantee of employment for all of our staff below board level, and we continue to meet them on a regular basis for an opportunity for questions, and also to continue team building and make sure that we're doing everything that we can to support resilience, confidence within our teams. So they're the statutory things we've got to do as a CCG. I just wanted to say thank you to everybody who contributed to the AGM that we held a couple of weeks ago. That seemed to be a successful venture. So thank you, everybody. It was also, and that was probably the last time we'll do that as a CCG in that way. But I also wanted to say thank you to a number of people about protected learning time. So protected learning time was this week. Many of you will have been involved in that. It was probably the last one that we will do in that way. It was a great success again. So I just wanted to say thank you to Nigel for the way he's led that protected learning time. And I might just ask Ruth, Helena and Chris to maybe give some thought to how our wider primary care colleagues who've benefited from that might want to recognise and mark the work that Nigel has led as we move into the next phase, where that work will be more primary care network focused. But it is an important milestone, I think. And in board meetings, you're probably not supposed to do this, but I'm going to do some shout outs, which is not really a board thing, but I'm going to do it anyway. So I'd just like to have minuted our thanks to Sharon Hegarty and her team, to Sam Varro, to Joe Baxter and Michelle Seidman and Vicky Binks, who's now left. Without them, the work that Nigel has led and the value that has been created, the momentum that has been built by Nigel's leadership would not have been as successful as it has. So I'll stop there. Nigel, thank you.
Great, thank you very much, and thanks for those words. Very, very kind of you. Helena.
Yeah, I just wanted to echo that and echo the importance of GP education and clinician education, bringing nurses and other allied health professionals together with doctors in a learning environment has been really welcome. I have, lots of feedback. Somebody told me, as Nigel, I think you already know, that they felt that the talk on Tuesday should have been turned into a Netflix documentary because they felt that it was so powerful. I think that speaks of the impact that this sort of stuff has. And I think it is really, really healthy to have normalised GP and primary care education as a routine activity, which I think you've taken this to be over the last couple of years. What was once a novelty is now a normal, expected form of GP education, which is really important and powerful. So well done.
Thanks, Helena. I completely agree. I think we do need to continue to embed it in as we go forward, but we'll have to see how that morphs into the ICS as well around that. Yeah. Okay. Brilliant. Thanks very much. Any other comments or anything to add to Phil's accountable officer update for anybody before we move on? No? Okay. So I just want to echo my thanks to those shout outs as well. So thanks very much, Phil, for raising that. So really absolutely agree with that. Okay, so that's the accountable officer update. So now we're going to go over to Michelle, and this is the quality and patient experience report. And that's to agree that the risks within that are being managed appropriately. But then after that, Michelle, you have got the COVID-19 updates. I don't know whether you wanted to merge those or whether you want to do them separately, and whether you wanted to bring Sharon in for that, but I'll leave it up to you. So you just tell me what you want me to do about that.
I will mention some. Oh, thank you. I will mention some bits about COVID and vaccination, but then after my report, if Sharon's okay with that, she can come in and talk to us about how it's looking in terms of COVID out there from a public health perspective. So I'll assume you've read the report. I just wanted to pick out a few bits. In terms of our independent care providers, so our care homes in particular, you will know that November the 11th is looming in terms of having to have vaccination before you can work in a care home or go into a care home. So that, includes anybody that goes into a care home. And that will unfortunately mean we will lose a fair few hundred of our care home staff unless they decide last minute to have it done. So it makes the staffing issues in that sector even more difficult. And we have a very, very challenged domiciliary care sector at the moment. So home care is particularly difficult, and that's having impact on being able to discharge people from hospital in a timely way. And the other particular issue is registered nursing staff in care homes is getting very, very difficult. And on the back of that, we've recently had to move a significant number of residents with nursing needs to other care homes. And you might have seen some of that in the press recently at St Catherine's care home in Sherburn. They are left with 4 patients who have residential needs and so who can stay there. But the rest of the patients we needed to move. So it's getting really tough out there in the care home sector. A good news story is that we are working with a GP who is hosted by Nigel in his Selby practice, who was looking for a a quality improvement project. And what we've done is use some of the infection control data to design with him a project to reduce E. coli, which is an infection in the community. And it looks from the data that the hospital, our local hospital, appears to be an outlier with regards to E. coli cases. And when we look at that, it's admissions from care homes, probably due to people being dehydrated. So there's a quality improvement project going on with this individual and with Sarah Fiore in my team to look at that from a quality improvement project point of view. The care homes are really up for it. We've done some previous work on nutrition and hydration, so it's going to be really interesting to see what comes out of that. You'll note the operational pressures that are in the report, and I'm sure we'll talk about that more as the meeting goes on. In every single sector, you know, including the police, right across our partners, and it is having a significant impact, and we're not even into winter yet. Excuse me. COVID vaccine. The next stage that you will have noted is the booster programme. You can only have your booster if you have had your second dose more than 6 months ago, or 6 months and more ago. And so people are being called to that booster programme, those that are over 50 and those that are vulnerable. And that's going to be, a real success story in terms of keeping people's immunity up. As we know from the data, it wanes after a period of time. And it would likely be, business as usual when we get into booster programmes. And also started to vaccinate the 12 to 15-year-olds. And I'd like to thank our schools and academies for being really supportive in trying to find innovative ways to vaccinate our younger children. The other particular issue for us as a system is that you might remember that during COVID, there was some national guidance out that came out to say that if you were a COVID positive patient needing a care home and you were being discharged from hospital, you needed to go to what's called a designated setting. And the designated setting guidance is a national set of guidance from PHE that describes the conditions that care home needs to comply with in order to be signed off by the CQC as a designated setting. We had, you might remember, Peppermill Court for residential patients in York, and we had nursing home care beds in Scarborough. We no longer need the residential beds, and so Peppermill was closed some time ago, and we had a reduced number of beds in Scarborough. What has subsequently happened is that the CQC have re-inspected that establishment and believe that the designated setting does not meet the guidance. And so we now have across North Yorkshire and York no designated COVID positive beds for people being discharged from hospital. They're very small numbers at the moment, but they do have impact. So for example, there was one patient in the hospital some time ago. We couldn't find a bed for them. He or she was the only person that fitted that criteria, whereas earlier on in the pandemic, there were significant numbers of people needing to be discharged who were COVID positive. And there wasn't a designated bed for this individual to go to, and that ward ended up having an outbreak of COVID because there were COVID contacts and spread. So although the numbers are very small, it's very significant. And what we are trying desperately to do is mitigate that and find alternative settings. But it's just a description of, all the different areas that are causing real pressures, particularly on hospital discharges and keeping that flow of people going through the system. Let me know if you want me to stop and ask me anything at any point. I'll just carry on if not. Tees, Esquire and Vale Services, our mental health provider, we have talked about on a number of occasions here, and the quality and safety concerns we have about this provider who is really struggling. The CQC have published their inpatient inspection report, which we've talked about openly here before, and our governing body have agreed to support with increased investment their inpatient staffing on a non-recurrent basis. So that will help them, at least in the short to medium time. And the quality board, which has been stood up on the back of the CQC report, which is led by NHS England, continues, and the CQC are pleased with the progress that TUV is making on their action plan around that. You'll note in the report that subsequently the CQC have issued a warning notice for forensics and CAM services that they inspected that's not in the public domain yet, as CHUV are responding to some factual accuracy checks in that notice. And so that will be shared at a later date. And they've also undertaken a well-led inspection, and we await the outcome of that. And that shouldn't be too long. We were told it was around October time. So, this organisation is under particular pressure from the regulators while it struggles with the same things that everybody does, in particular with regards to staffing. We talked here before about the particular pressures on community staffing, supporting primary care, and that's not looking much better at the moment. Real struggles to support that. But when we look at CHUV staffing overall, unfortunately, it's not community services that are the most pressured within this organisation. There are areas that are worse than that. And through the contract management arrangements with CHUV, we discuss this on a regular basis and have certain amounts of assurance and mitigation, but they are in a tricky place. They are out to consultation on a new structure that they're having at the top level of the organisation, and that's been sent round to partners as well. So I'll just stop there about CHUV at the moment and see if anybody wants to ask me anything, or Denise wants to come in at any point. No? Okay. Another good news story. One of the issues that we are facing is a potential surge in respiratory infections for our youngest of our community, so aged 0 to 2. And that's been modelled on international data. And what we're expecting is this surge in respiratory infections earlier in the year, and we usually see it during the winter. And so that has led us to look at a more innovative model in order to stop these individuals going to hospital where they don't need to. And what we've also found during the pandemic is that young parents have lost some confidence over being able to look after a sick child. And that's not surprising, because they haven't had their community networks or been able to go out to, baby and toddler sessions and where they meet other parents and have those conversations, or even been able to see family members. So that's a significant issue. And so we have set up with partners in Nimbus Care and with the hospital an innovative model, and it's called PATH. So it's Pediatric Ambulatory Treatment Hub. I think that's what that stands for. And it started on October the 4th. And it's open for an 8-week pilot from 4 o'clock till 10 o'clock. And we started to see a little dribble of patients through there to test this pilot out, but we are very confident it's going to really help the system. In other areas around children and young people, another good news story is that we have a post, somebody that has started within York Hospital whose sole job in life is around transition of children to adult services. We know that sometimes these children can not get the best care that they had while they were children when they moved to adult services, and the preparation for that move is often not as good as it could be. So one of those things was picked up in the Ofsted inspection for SEND as well. So we're really pleased that person's been able to start, and will make a big difference to those children, young people and their families. The other thing I wanted to note, and we don't talk a lot about this, is end-of-life provision for children and young people. In our area, we have a number of children that die, that are end of life and palliative care each year. And what we can see across our ICS is that there is big variation and inequity of provision. And that's mainly due to availability of that provision and where the hospices and other services might be, but also in how the finances might have been arranged historically to support end-of-life care. So we're doing a big piece of work across the ICS under the Children and Young People Alliance, for which I'm the SRO, to try and even that out. It will take some time, but doing some self-assessment, doing some joint working and collaboration with partners across the system, and hopefully we will see that inequity smooth out. In terms of our SEND inspection, and we talk about this on a regular basis because good progress is being made around the written statement of action that we've had, and just wanted to point out the co-production of the 7 SEND outcomes that we did with children and young people, and you can see the graphic there and the I statements that our children and young people wanted from SEND, and it's been a huge piece of work, and I'm pleased to say that it's concluded and they've made it very clear what they really want in terms of outcomes. It's a good piece of work. Another good news story is that we have managed to reduce the rate of smoking at delivery for in ladies who are pregnant from 15% to 8%. It's it's hugely significant, this. It's been a sticky wicket for quite some time. The model that was used has been quite different in that they listened to mums who smoke and said, what would it take to help you and support you? And that was put into the research of the model, and with public health and colleagues at York Hospital and Primary Care managed to reduce that. And it's a really impressive reduction actually over a fairly short period of time. National GP survey, you can see that is in the papers, quite a lot of information there that's been pulled together. But what I would say is that every indicator, bar one, and that's the bar one is only a percentage different, shows an improvement from the last survey. Despite the very negative press that GPs have been getting. But what we do see is huge variation in the results across practices. And we are working with practices to try and smooth that out. So, for example, some people would get a really positive 100% response rate to a question, and in other practices it would be down in the 40s. So that there is big variation across our practices in the way that people view their services. The risks that are owned by QPEC, you can see there that are being managed, and the chair, Julie, has given you a summary of her view of the last meeting. And just to note that there is a new one there around maternity services at York Hospital that you will have read. It's mainly due to staffing, that they are unable to meet some of the recommendations of the Ockenden report, the better birth rate, and also their CNST standards, so their insurance. They're doing a lot of work around that, and you can see the description there. And we're meeting regularly with the trust to understand what that means. And they've had a recent, I'll say inspection, but review by the LMS across the system, just to see how they're doing with their continuity of carer. And continuity of carer means that they, it's an initiative whereby the plan is to try the best you can to make sure that women have the same midwife right throughout their care. It's a really difficult thing to achieve, especially when services are pulled in different directions and you've only got a certain amount of staffing. And sometimes, the thing that goes away is the ability to be able to see the same person all the time, and also to have your wishes granted, such as home births. So I just wanted to point out that new risk. And the risks that are owned by governing body here, the Hep B that's been going around for quite some time is in the final stages of development in order for the acute trust to take on this service. That is no longer commissioned in primary care by NHS England. So we're very hopeful we'll finally get that over the line. The 0 to 19 service that we've talked about here for North Yorkshire has now concluded its consultation, and I've received the document which describes what the new service will be, but it was out of time for this report. So what I'll do is I'll send it round so that people can see what the outcome of that is, and how they've listened to people that have responded to the consultation, and you can see what the end result is in terms of the service that's going to be provided. So I'll send that round and we'll talk about it more next time and at QPEC, if that's okay. And then the other risk managed by a governing body is TUVE, and we've talked about that. So those are the things I just wanted to highlight.
Great, thanks very much. Sharon, you want to come in?
Yes, thank you for the report, Michelle. Very comprehensive and accessible to read. So thank you for that. I just wanted to make the governing body aware that the Healthy Child Service in City of York recently had its first inspection actually since transferring to the council from CQC. So I haven't had that report yet, but as soon as I've received it, I'll share that with governing body members, so that you're cited on any issues relating to the Healthy Child Service in York. Thank you.
Great, thanks, Sharon. And Michelle, just picking up on maternity services, I think there's been a pressure probably across all of the UK, but definitely across our region, isn't there, about maternity services, just on the volumes of the service that's required at the minute. So people are finding that there have been transfers in and out of certain areas and settings. So I was just going to highlight that the pressure is unprecedented across all aspects of health and social care at the minute. Okay, if anybody's not got any other comments for Michelle for her quality and patient experience report, I just want to make sure that we're assured that the risks are being managed appropriately, and we do agree with that, so we can have that decision ratified for the minutes, and if that's okay. Yeah. Then the other bit would be, Michelle, do you want to update anything particularly about COVID-19, and then bring Sharon in if there's anything from your perspective, Sharon?
Yeah, no more than I've just mentioned, really. So if Sharon's happy to come in and contribute, that'd be helpful. Thank you.
Yeah, so I can give you a population overview as to what's happening with COVID, which is probably useful. COVID is still circulating at quite high levels across North Yorkshire and York. So the City of York has the lowest rate of infection in the Yorkshire and Humber region at the moment. North Yorkshire is slightly above where we are. So just to give an example, the rate for York is 239.8 per 100,000, which represents just over 500 new cases of COVID in the last 7 days. So quite a high number. We're still having people in hospital identified with COVID, not necessarily admitted to hospital with COVID, but obviously everybody who's admitted into hospital gets tested. And so some people are testing positive for COVID, having been admitted to hospital for some other reason. Those numbers are staying fairly stable at the moment, at around between about 30-40 patients at any one time, and low numbers in ITU beds. We're still seeing some deaths from COVID across North Yorkshire and York, but again, small numbers, which I think really reflects the success of the vaccination programme, as we've discussed here before. The largest numbers we're seeing are in primary and secondary school age children. And our rate has gone up over 1,000 per 100,000 in secondary age children, and North Yorkshire is seeing a similar picture. That isn't just North Yorkshire and York, it must be said. This pattern is the same as what's happening across the region and across the country. Obviously, as the vaccination programme for 12 to 15-year-olds starts to be rolled out, we would expect to see those numbers start to fall. But I suspect that will simply push the numbers down into primary age children who obviously are not eligible for vaccination routinely at the moment. As we head into winter, we're not just concerned about COVID, also concerned about flu, other respiratory viruses, norovirus, etc. And so part of the approach across the city at the moment is to try and shock people out of the complacency that has clearly been created over the last few weeks and months in reminding residents and businesses, visitors to the city, that as we're expecting a difficult winter, there are simple basic infection control measures that are effective against not only COVID, but also flu and other viruses. And indeed, Nigel, you and I have both sent a letter to residents, which should start to land on all residents in City of York doormats over the next week or so. Also preparing to do a citywide campaign in partnership with businesses, really promoting three things. One is for all settings to promote the use of hand sanitizer, particularly in shops and supermarkets, etc., that hand sanitizer is visible as people walk through the door, and that visitors are encouraged to use it. A request that all staff wear face masks unless medically exempt, and also encouraging visitors to the city and shoppers, etc., to wear face masks as well. Since the change in legislation, the wearing of face masks is not mandatory in non-healthcare settings. But obviously there is a lot of evidence to show that the wearing of a face mask is very effective at protecting that individual and protecting others. So that's a campaign that we'll be encouraging over the next period as we head into winter. And we'll be talking to our NHS colleagues, because I think it would be helpful if that was a joint campaign. So that's kind of a quick overview, Nigel, as to where we are, and I'm happy to take any questions.
Great, thanks very much, Sharon. I completely agree. Prevention better than cure. We've got to make sure that people wash their hands, do all of those things that you've talked about, and be careful over the winter. It's going to be pressured, isn't it? So yeah, absolutely. Thank you very much. Any comments or queries either for Michelle or for Sharon? David, thank you.
Michelle, I was just interested when you said, you know, that people working within the care settings by November 11th will have to have be vaccinated. So, I mean, you said about 200. So, I mean, actually people are just going to resign their posts, are they? Because, I mean, that's going to be a tremendous gap, isn't it, in terms of providing services. And if you multiply that across other sectors, it's going to be quite significant.
It is, and it's a few hundred. It's more likely to be more than 200, David, across North Yorkshire and York. And there was a consultation on it, a national consultation, and there was a grace period in order for them to change their minds. And there will be, you know, people who, from an exception point of view, can't have it, but they're very small numbers. So yes, it's a choice thing, and unfortunately, you know, the pull of retail is very significant. You know, the average wage for a care home worker is £8.60, I think, an hour, when you can work at Tesco's for £15 and Amazon for 20. And of course, we're running into the Christmas period where people are wanting in retail even more staff to help them. So the pull is very strong, and that's where we're seeing people going, unfortunately.
No, that's a real worry. Thank you.
Thanks, David. The other thing, probably, Michelle, just to pick out was just to make sure for people that may be viewing, is that the RSV hub that's been run is accessible through your GP, isn't it? It's not you can't just turn up. So it's accessible through primary care because it's a triaged model. Yeah, thank you. Okay. Any other comments? Otherwise, we'll move on. Thanks very much, Sharon. Thanks, Michelle. Okay. So just looking at the agenda, we're now over to to Abby for the border assurance framework. Over to you, Abby.
Thank you, Chair. Yeah, so the board assurance framework I'll take as read. We've tried to highlight in red any of the significant changes. I think what you're going to start to see now is us morphing towards trying to do things once so that we get almost an ICS approach to this. So some of that is going to come from having to work through what the risk tolerance of the ICS is. And I know, Nigel, some of that work's already started from the clinical professionals group, and the governance group are doing some of that work as well. I just wanted to highlight for the risks table at the end, we've swapped over a risk that was highlighted as IG01 for an IT risk, and that's following the DSPT toolkit recommendation that we have to have something on there that relates to cybersecurity. Simon and I argued quite strongly about the way that that would be done, given that we've got quite a mature approach to risk, and this was seen as the solution to that is a low-level risk. So it's not that we've suddenly developed a significant concern about NECs and the ability to deal with cybersecurity. It was just something that we needed to do to get through the IG toolkit. There are also 2 risks referred to on there that relate to ongoing employment matters. I'm not able to put any detail within the risks, but they will be reported at a later date. And Nigel is currently identified as the owner of those 2 individual risks. So unless there's anything specific, I think that's probably all I need to say, Nigel.
That's great. Thank you very much. Very clear risks in the border assurance framework, and thanks for explaining the IT one as well. Anybody got anything that you want to pick up on that as we go on? But I'll be just thinking about when you're saying it, how we're sort of going to integrated care systems and the risk that's moving over towards them. So how will that actually happen in practice, do you think? How will our risks sort of will that be sort of lifted up and taken by the ICS, or will they agree to those risks as well?
Yeah, so I think most of this is going to sit with me. So in one sense, we've sort of got a bit of ownership of it from York in terms of the ICS approach that we're going to take. I'm trying to get the ICS to take an approach like we have, which is to agree a risk appetite statement and to agree thresholds. And then there's also a stock take through all the CCGs that will feed into our ICS of what risks they've currently got and how they are scored. And then we'll have to pull all of that into one document. The harder bit, I think, but the ambition is that providers will fall in line with the same risk appetite statement. So their risk registers, certainly through provider collaboratives, even if it's not their own individual risk registers, will score in a way that we recognise in the ICS so that we have a system approach to risk. I think the role of CCGs when we're starting to propose the constitution is to be really clear with our own risks about why we've got that appetite, why we think those risks are so significant, and that we're proposing those to the ICS. And then certainly the role of those groups that sit within the ICS, so the clinical professionals group that you chair, Nigel, is to influence the risk appetite statement as we move through that. And then Simon, again, will have to do finance side of that as well.
Great, thanks for explaining that. Thank you. Okay, if there's no comments for Abby, we'll just say thanks, Abby, for presenting that, and we've received that. So that brings us now on to agenda items that we're talking about under assurance, and we've got 3 pieces here that Michelle's going to talk to. So thanks, Michelle, you're doing a lot of talking today. Thanks for doing that. So item number 10 is learning disability mortality review. So over to you, and then we'll take comments from that, and then we'll move on to the other bits as well. So over to you, Michelle.
Thanks, Nigel. I did want to spend a few minutes on this and picking some bits out. It's in the forefront of our minds often at governing body, and when we've had a previous annual report here, it has galvanised us to do some innovative things, which is making a difference, and I think that's important. So this is the North Yorkshire and York Learning from Deaths review in people that have a learning disability, and you can see the exec summary on page 71 and the background as to how the leader processes and systems came about. And CCGs have a particular responsibility to make sure that we have a system in place whereby we can review every death of anybody over the age of 4 who has a learning disability and who dies. And previously, you might remember that the thing that shocked us most, I think, at governing body was that compared to the national figures, people in our community who died with a learning disability died 5 years earlier than the national average, and we took that conversation to a number of forums, and it has really stirred people on to look at this issue more seriously. And this time the average age of death in females is 65.7 and in males it's 66.7, and the national figure is lower than that, so females 59 and males 61. So that is a big difference, and we don't want to read too much into it, but I think that that is an improved figure of the length of time that people are living to before they die with a learning disability. We're talking about 55 people in total over that year, of which 18 of them died from COVID. 5 of them were children. 56% of them are over the age of 61. And the biggest increase in the age group is those for age 41 to 60, and that's due to COVID. And that's gone from 22% to 37%. So some of this data is incomparable to previous years, really, due to COVID and the unprecedented times we find ourselves in. There's been an increase in deaths in people that died in hospital with a learning disability, and that reflects the national figure and is related really to the COVID deaths. Just to put this into perspective, people with a learning disability still die much earlier than the general population, and you can compare it to the general population in the 1940s. I think that's the stark reality. And we do have now a national NHS policy on leader, and that came into effect in March this year. And it will, from the autumn, also include those people who die who have autism. And the ICS will have a particular responsibility around this, and will take on the responsibility for the employment of staff that currently undertake the leader reviews, and must build it into their plans for reducing inequalities. I think the other significant achievement is that over North Yorkshire and York, we have been able to review every single one of those deaths, so met our target. Sometimes it takes a long time to get into all the detail and get all the information that you need to review those deaths, and we've managed to hit the target of all of those being reviewed. In terms of the causes of death, 34% were due to COVID, and 30% were due to pneumonia, and pneumonia was the biggest cause the last time we got the annual report. 12% cancer, 14% circulatory diseases, and 5% sepsis. The national figures are not yet out, so we can't compare ourselves to that just yet. In terms of the Stomp Initiative, which is about stopping over medication for people with a learning disability, particularly psychotropic drugs and antidepressants, we have made some inroads to that too. So 25% of people who died were on psychotic drugs, and that's an increase of 2%, but 7% lower than the national average, 7% better than the previous year. So we are making some inroads into absolutely making sure that medication reviews are done and asking the question, do these individuals really need to be on this medication? And the average of people who died who were on antidepressants was nearly 23%, and the national average is 27%. So that's also an improvement from the previous year. In terms of annual health checks, we've talked here before about the real success story of taking this initiative and driving it through, and you know, the trajectory is 60% of people with a learning disability having an annual health check, and we've got 79.5%. It might be better than that even now. And well, 79.5% of people who died with a learning disability had an annual health check. And this is the interesting bit. So of those who died, 79.5% had an annual health check, but 91% of them had a meds review. And there's a question within the report about why those two things are distinct. And perhaps a question for primary care about a medication review versus an annual health check, and why the annual health check figure isn't higher if we're getting a medication review done. That's the question from the report that we need to look at. But the generic screening program, such as for bowel screening, has a really low uptake for those with learning disability, and then probably, you know, relates to the percentage of people who die with a learning disability from cancer. In terms of those who had a do not resuscitate plan in place when they died, 40% of them did, but the reviewers felt that the vast majority of those were appropriate. There is a line in there where they did discover a review that had said that the reason that somebody had a DNA CPR in place was because they had Down syndrome, and that's not acceptable practice. So in terms of learning, drive up the LD health checks is the recommendation. There are also some valuable lessons around the application of the Mental Capacity Act that could be improved as well. Detecting earlier deterioration, interventions for when people have a high BMI, we felt we could do better in terms of helping people with a learning disability who are overweight to lose weight, and then the routine screening issue as well, and see if we can drive the figures up in terms of detecting disease much earlier. So that's a summary, but a lot of good in that and a lot of learning still.
Great, thanks very much, Michelle. And just reflecting back on our protected learning time keynote speech from Jessica Allen, she would say that people with learning disabilities wouldn't even get onto the lower centiles of health outcomes and health inequality. So they don't even get onto that worst bit that we see. So it's really important that this is absolutely highlighted. Helena, would you like to comment?
Yeah, so I just wanted to make a couple of comments. So the first thing about is the medication review and the annual health check. I think in most practices they're done as two distinct activities. Annual health checks are often completed by senior practice nurses or advanced nurse practitioners who are not in a position to be reviewing the medication. So that will often be done by a combination of a clinical pharmacist and or a GP. And the other thing is that if people don't come for an annual health check, if they decline it or we're not able to, for whatever reason, make that happen, they obviously still need a medication review. So that medication might be done in absentia, but that's not because of neglect in my experience of the medication review process being face-to-face. And someone might consent to contact without having a full annual health check. And so, you know, clearly a medication review might occur in that setting as well. And the second thing I wanted to mention was about learning disabilities, high BMI and weight management. So it is my experience that people with learning disabilities and SMI actually, who have a high BMI, who would be appropriate for weight management support, cannot access, for the same reasons that primary care access is difficult, cannot access suitable weight management support for their needs. I'll speak for my area, you know, that practically speaking, the only service that can meet the needs of somebody with complex learning disabilities or very difficult severe mental illness is a one-to-one service that will typically be offered more than 20 miles away from where that person lives. And if we consider the health inequalities around transport and poverty that are often associated with those conditions, then that becomes an inaccessible format. So I do think there's a really important question as we embrace weight management services and we really encourage our practices and everybody else to be really referring people with obesity. This is a gap. This is a gap we need to recognise. And the referrals, the lack of opportunity to refer is often the reason. It is not an inertia to the fact that their obesity is important, but there is not a service that meets the needs of these individuals well, that is readily accessible to them.
Yeah, very good point. Very good point.
Thanks, Helena.
If Sharon wanted to come in.
Yeah, Denise or Ruth? Yeah, Denise.
Yeah, thanks, Nigel. I really would just echo what Michelle says. You know, we don't want to be complacent about it, but what good news, really, and what a move in a year. And this is something that we talk about, and I know in general practice is talked about a lot. So I think we've changed the outcomes and also changed the culture of health practitioners. I suppose the one thing that I'm still thinking about is whether or not we've got any assurance that that clinical decision making isn't taking account unnecessarily of a learning disability. So an example might be that somebody is identified as having a bowel cancer or a breast cancer, and that are we assured that actually the same treatment options are offered to them, recognising people may be fit for surgery or may not be, but fit for surgery shouldn't really be about somebody's diagnosis of a learning disability. And I know that might be next stage down, but it is something around, in general practice, there's a culture change already. Are we assured that in the hospitals, in surgeons, as an example, there is equally that culture change?
Yeah, I think that's a very good challenge to us all as clinicians. So thank you. Yeah. Ruth, do you want to come in?
Yeah, two things really. One thing is that all the time, there's a real predominance of respiratory, like chest infection type deaths. And I just wondered why we're not picking up things like speech and language therapy assessments and swallow assessments sort of as a potential kind of thing that we might be able to do to help prevent that, because I do wonder if that there's a link. There may not be, but I didn't see that coming through. And the second thing is sort of really picking up on what Helen is saying. I think it's really important that the annual health checks is great that we're doing them, but it's not enough. That you've got to be focusing on the what next. What are you finding, and how can we make services accessible for people with learning disabilities? And that's all of them. That's potentially not, I mean, smoking, obesity, loads of things really. So I think we are doing a bit of work in PCNs around that. I think it is something that we are trying to pick up, but it's about how we make that now the next most important thing. Now that we're doing the health checks, what are we actually doing about what we find in the health checks really? So we need to push on and go to the next step really.
Yeah, thanks Ruth. Michelle, anything you want to come back on that? I was wondering about, when I've listened to that, what we could push on at an ICS level around this, and around those aspects that Denise talks about assurance into secondary care as well. But that was just some things coming to my mind.
Yeah, there are two things for me. How do we, like we did before, turn this report into a set of actions for us as a CCG? What could we do, and what needs to be done? Because I think people took individual responsibility and pushed on the LD health checks. But as a system, what are those things that we could carry into the ICS? And what I'm hearing from you is particularly the BMI and the screening question. And then I will go back to the reviewers and ask the question about was swallowing and salt a particular issue. It would be unusual for for it to be an issue and not to appear in this report. So I'm guessing that it wasn't an issue, but you make a good point. But there clearly is a link to being very overweight and being able to, you know, manage a chest infection. What we have been doing is in the last year we have appointed a member of our team of nurses who support independent care providers and go out and train the staff that work in residential care, looking after people with LD, on those physical signs of deterioration. And that's making a difference, because they're often LD nurses and carers who haven't had that sort of physical health training, and that's making a difference to them being able to recognise that somebody is becoming sick. So those sorts of initiatives I think are important, but it's how we turn this report into a set of actions that can be carried into the ICS. And then the second bit is that there is a plan, Nigel, for me to bring a report to the transitional ICS exec on this, in terms of what the ICS responsibility needs to be for leader and how we set ourselves up properly for that. And then the next stage will be, how do we integrate that into the work streams that we've got going and make this a priority.
Great, thank you. Ruth, just picking up on your points about the so what and what next, but have you come up, because I know you've done a lot of work in Selby around this and championed this. Have you sort of come up with across lots of blocks about the what next bit? I'm just trying to understand how we reach out to other agencies or start to unblock those sort of pathways that Helena talks about around access to services. Have you got any thoughts on that? I know I put you on the spot, but I'm just thinking.
No. I was thinking really about the population health management thing that we did in Selby around hypertension and frailty, but how you could sort of pick out a similar approach, really, I think, to people with learning disability and annual health checks, and what we're finding in the annual health checks, but also what matters to them as well, because that's just as important. So are we coming across any barriers? I mean, I would agree with Helena that there doesn't appear to be easy access to the things that you might want to do with regard to exercise groups. There are some, but exercise groups, healthy eating, all those obesity type things. So but I think taking that sort of population health management approach and then doing some really targeted work is probably the way forward in PCNs, as far as how we approach it, and approaching the voluntary sector to see what they have available. There's some really great learning disability charities in Selby, but it's how can we support them, I think, to then pick up the what next, or work alongside us about the what next, really. So yeah, I think it would be a great piece of population health management work to do, definitely.
I'm wondering if there's a role for care coordination too for LD. We know it works. And
I mean,
have individuals that that coordinate their care on behalf and have that signposting ability of every service that's out there. I wonder if that is worth scaling up from what SHAR has in place, for example.
We do have we did actually have an LD health care coordinator, an LD and SMI health care coordinator. She's actually left, so we're looking at reappointing someone. She initially was really working on the uptake of the annual health checks, but the plan was to move into exactly that sort of what next and connecting. She made quite a lot of connections locally, so we just need to build on that, really. But you have to set targets to try to to get the change to happen. I think we really do have to be bold and set ourselves some really clear targets to say, want this percentage of patients to improve or to have had access to some sort of a exercise group or a health eating group, things like that. I think we need to set clear targets for it. So. But yeah, I think we'll work on it in our PCN, but I think maybe we need to look at it wider than just PCNs, and sort of a steer from the ICS would be really good.
Helena?
Yeah, so I've got a Vale, not City, but Vale meeting about obesity this afternoon, and I think this needs to form part of that. So I think the challenge is that the services that exist are not designed for these people, but we do need, when we've not been referring into them. Now our eyes are open to the fact that there's a need. The health checks are happening more often. We now need a service to meet that need, and so as the awareness has grown, that the gap has become more obvious. So we need to think about that, and I think the challenge here is who has the power to meaningfully do that. We'll probably need to discuss this with learning disabilities teams that already exist and have dietetic input and everything else. There is expertise out there, so it's how we move it towards the need that we're experiencing, rather than perhaps some of the acute needs that come up or in the end of life care kind of end of the spectrum.
Great, good points. Thanks for that. Thanks, Michelle, for that. Anything further that you wanted to point out about that? I think it's a really good discussion about how we energize that sort of movement around proactive care in learning disabilities, isn't it? So great, thanks very much. Okay, so the next two items are sort of linked, really, aren't they? But so I don't know whether you want to do them as a one or as a two.
I'll do them as a one. So
okay.
I wasn't going to pick out too much from it, other than to say you've got before you the North Yorkshire and York Children and Children in Care report, and this is from the designated professionals that we employ as CCGs, who are subject matter experts and to support frontline workers as well in terms of how to get good practice in terms of safeguarding. And you can see from their report that it's been a really tough year for children. I'll come back to that in a second. And then the second report that you've got is the City of York's Children's Partnership, which used to be called the Children's Safeguarding Board, and how they have been able to get assurance on behalf of the system, which is their role in how services are connecting and collaborating to keep children and families safe. So in terms of the Children in Care and the Children report from North Yorkshire and York professionals, the impact of COVID on children has been very, very significant. And I know that you know this, they've lost family members from COVID. There's been a lack of support in community because services weren't accessible, especially for people with young babies. And we've seen an increase in safeguarding around injuries to young babies too. Children in care have been unable to access contact from family members. There's been an increase in domestic abuse and a decrease in education provision. And what we've seen is an increase in referrals from an initial dip during COVID. And children have experienced very significant emotional and mental health problems. And now, we are seeing huge increases in referrals right across the system to access support for that. But despite those challenges, we have got really robust arrangements in place to try and manage this, and have adapted and morphed into different ways of working, which you can see on page 110 around what the key achievements have been. But there remain, a lot of challenges, and we've been able to prioritise what we need to do next. And there's been some very innovative practice that's happened during this time. I think it's important to just note that the domestic abuse bill now puts children who witness domestic abuse as not just witnesses, but they are victims now as well. And that's important, and we need to change the way that we support those children who are witnesses to domestic abuse or who suffer domestic abuse themselves. And just to say, from the Children's Partnership Board report, I wanted to say a big thank you to our relatively new scrutineer, Maggie Atkinson, who came to us. She was the person who actually did the independent review, and Amanda Hatton came into post. And when we got a new Children's Safeguarding Board chair, you'll know that as we are responsible as one of the 3 statutory partners for safeguarding, along with local authority and police. And she did our independent review and made some recommendations, and then she actually came in to be our independent scrutineer. And she has done a scrutineer's report as well, And her view is that we are in a much better place in terms of our systems, processes, governance, and some of the things that we're taking forward. So that should give governing bodies some good assurance around that. So that's all I was going to say.
Great, thanks very much, Michelle. I suppose with my hat on as named GP for safeguarding, I just want to echo your thoughts that we're in a much better position. I think the investment that the CCG has put into nursing provision across primary care has been massively supporting to primary care and protective to families and children. And we now have much better processes in primary care than we've ever had before over the last 4 years. So I just want to thank you for championing that. What do you think, or how will the arrangements change as we go forward from April 22? Is there a specific thought about how that will happen?
So it's really clear to me that we've got to keep business as usual going. I think during the transition, that's really, really important. And the safeguarding professionals have worked together really well to identify what needs to be done going forward. And I think the main changes are that we don't lose the focus on it, that we have to be really clear how we support safeguarding boards, both adults and children, going forward, because what currently happens in terms of representing health, other than some providers around the board, which has a different lens, is that they're used to having the exec nurse from the CCG on each of those safeguarding boards, and CCGs won't exist anymore. So we've got to make sure that they get that senior health representation on those boards going forward. The other thing that's clear to us and has been accepted by the ICS transitional exec is that we need a transitional role that focuses just on safeguarding, making sure the arrangements are right. And that's been agreed, and we'll start as soon as we can identify that individual. But it will be somebody from our existing resources who's really keen to take this forward. We do need to have a set of governance arrangements in place. That again has been signed off by the ICS exec and is just gone through to NHS England for sign off. There's been a significant amount of work gone on, but I think it's important to say that, from my opinion, certainly from what you get as frontline staff, won't change and shouldn't change in the short to medium term. In fact, we want to bolster it. Having said that, the designated professionals, those with that real skill, are like hen's teeth. They're really hard to find, and that service is very fragile. A lot of those individuals have retired and returned. And we have got some gaps across the system. So we do need a significant piece of work on growing our own workforce around specialist safeguarding. And that is beginning to happen, but that would be one of the priorities. And I'm happy to bring back a more focused piece of work, if that helps, around what we're doing around the priorities for safeguarding going forward for the ICF.
Yeah, that'd be great. Thank you very much. Thanks for that. Any comments or thoughts for Michelle before we move on? I think you can take a big, deep sigh now, Michelle. I think you're no more talking for you for a bit, so that's good. So thank you very much for presenting everything today. So that brings us on to our finance piece. So this is over to Simon Bell for the finance report, and then you've also got the update to the detailed scheme of delegation. So I don't know whether you want to run those two things together or separately. I'll leave that up to you, Simon.
Okay, thanks, Nigel. Month 5 report with the governing body today. So in summary, forecasting a break even for half 1 at month 5 on plan. Within that, however, reasonably significant overspends on continuing healthcare and prescribing. We would expect that to continue into half 2 of the financial year. In terms of half 2, we received the allocation for the CCG and the wider system, along with guidance on the 30th of September. So that's for the period that starts 1st of October. Plans for that period, final plans have to be submitted by the 16th of November. We're working through the detail of that. In summary, we expect that to be a more challenging financial position. So ignoring the euphemism, what does that mean? That means we have less money as a system to deliver the services that we are required to deliver. So less money to spend on COVID response, less money on hospital discharge program, and overall less money. We would expect that to continue as a trend into next year. Phil mentioned earlier two significant elements of funding that remain out with those allocations. That's the Elective Recovery Fund, aimed at reducing elective waiting lists, and the Hospital Discharge Programme. The operation of the Elective Recovery Fund will continue to be managed across the ICS. So that's taking into account the performance of all organisations, such that if one organisation failed to deliver its targeted trajectory, that impacts the amount of reimbursement all of the organisations in the ICS would receive, regardless of their performance. It's become probably more complicated again than it was in the first half of the year. The management of the independent sector capacity and the NHS capacity will be separated. Independent sector will be based upon 1920 volumes. So if activity is above those, that outturn level in 1920, that will be reimbursed. For the NHS, it will be based on 89% of referral to treatment times trajectories being achieved, and that's a change from the first half of this year. It is, with multiple organisations across the ICS, a difficult piece of work to try and predict what exactly we think that will look like over the first half. So significant volatility in that area. To give you an example of the scale of that, the original ERF was planned at triggering at 85% of 1920 volumes. That changed to 95% in Q2 in a way which we hadn't initially expected. That meant that as an ICS, we lost a planned £17 million of income, so quite significant. So we're working through ERF. Hospital discharge programme, again, less money than in the first half of the year, round about £1 million less. We have moved from a 6-week package of care funding to 4 weeks now being funded centrally. We've made an initial assessment of that. We think for York, the health and wellbeing area in York, that's probably a cost pressure of about £500,000. And we're still in discussion about that. But that's a very broad brush walk through the current plans. We'll probably have more idea of where that specifically leaves us as an organisation and as a system in the next 2 to 3 weeks. Again, deadlines 16th of November. Overall, less money than we had in the first half of the year. But Nigel, I'll probably pause there before going on to the schema delegation, because it's a bit of a different thing, just to see if anybody's got any particular questions on the month 5 report, the forecast, or indeed anything I've said around half 2.
Yeah, I'll pause there. See if anybody wants to come in. Yeah. I think you're all right for that. I'll just check. Yeah, okay.
Okay, good. So scheme of delegation, this is one of the main control functions that the governing body has to exercise. It's the way by which the organisation manages its governance across significantly financial and contract controls. We put in place a series of changes to that in response to COVID. This is a refresh of that now that we are where we are in the COVID response. So there's broadly 3 things that we're summarising here and proposing that we change. And this report's been through exec committee, so everybody on the exec team's happy with this. Those three things broadly, we're proposing that we stop some of the changes that we made during COVID. So one of the changes was around credit card. We allocated credit cards with significant freedom to spend to two of our directors. We haven't really needed to use them over the period, so we're proposing that we bring those to an end. We are proposing that we keep other changes that we've made. So the hospital discharge program arrangements that we put in place, those we're proposing that we continue because that funding will continue. We are expecting that funding to come to an end this financial year, so we're not expecting that it will continue into next year. So on transition into ICS, we'd expect that would need to be picked up and changed by the ICS. But so that we're in good shape through the rest of this year, those are things that we think we need to keep in place. And then the third tranche of things we've changed are just looking around at how we work as an organisation and just testing that the scheme of delegation is fit for purpose. We've introduced a couple of things that just reflect our custom and practice that weren't specifically set out in the scheme of delegation, but probably ought to have been. One is around execs and other budget holders being able to nominate deputies in their absence, whether planned or unplanned, and what happens if there's an emergency situation, something needs to be paid, but nobody's around to pay it. We didn't really have a default solution to that was written down. So the scheme of delegation tries to pick all of that up. And the other thing it tries to address is what happens when the CCG gets hypothecated funding. So a good example of this is winter funding. We're usually told it won't come. And it's all in baseline, and then every single year something additional comes and there's a big scatter as people try and find things to spend it on. We've just tried to capture that reality in a passage in the scheme of delegation, which is around hypothecated funding, which is impressing upon people a need to continue to think about value for money and our procurement and contracting responsibilities without necessarily trying to get in the way of something that typically lands at the last minute, and by virtue of the fact that it needs to be done quickly, we need a fairly slick process to make sure it happens. So we've worked across the organisation to try and make sure this scheme of delegation is as up to date as it can be and reflects our current custom and practice. Exec team are happy with it. No doubt once we've approved it, we'll find a situation that it doesn't quite cover. That inevitably happens, but it's as good as we can get it for now. And I'd like to extend my thanks significantly to Caroline Goldsmith in the finance team, who has the unenviable task of trying to keep track of this, keep it up to date, and make sense of all of these rules and regulations. So she's done a cracking job in making sure it's in the state you find it here today. So it's just for the governing body to approve. This is one of the things that the governing body has to do. It can't be delegated to anybody else. So here for approval.
Great, thanks very much. David, did you want to come in?
Yeah, I think as a governing body we should record our thanks to Simon and his team for maintaining more than adequate assurance over the difficult past year, and within the performance committee we do look at these in some detail, and we have in the past congratulated Simon and his team, but I just wanted to report that to governing body that we do have a very good level of assurance regarding our financial status, even during these very difficult past months.
Thanks, David.
Thank you, David.
So if everybody's okay, we will approve that. And Simon sort of echoed the thanks from David to yourself and your team, and to Caroline for the detailed investigation thing that she does. So thanks very much, and please pass on our thanks to your team. Okay.
Will do. Thank you all.
Right, so we're coming towards the end of our meeting today. So just pointing out some received items that are in the agenda pack for people to be able to see, and for transparency, understand what's been going on over the last few months. And before I bring the meeting to a close, Phil, is there anything that you wanted to come in on, or any other business to report?
Thanks, Nigel. Maybe we should just say something briefly about the ICS arrangements that we anticipate and what that means for our own CCG governance. So we anticipate the Humber Coast and Vale ICS governance arrangements potentially starting in shadow form from January 22, maybe a bit earlier, unlikely, maybe a bit later, possibly. What that means is that from that period on, we'll see a transition of the governance from CCGs in Humber Coast and Vale to the ICS. Between now and then, we'll make sure that the CCG committees beneath this governing body continue to meet on a regular basis. So we'll continue on behalf of the population of the Vale to take an overview of quality and safety issues and of financial and performance issues. We'll report those back into governing body on the 2nd of December. Between now and then also, we'll, as I mentioned earlier, be starting the due diligence exercise to close down the CCG and to make sure that the work that we have to do for a safe transfer of staff is well progressed. We do anticipate meeting again in public as a governing body after December, sometime between January and March, so probably February. And we'll do something similar then in terms of making sure that the transition to the ICS is transparent and secure, and making sure that we have a public-facing discussion about the quality and safety of the services that we commission, and making sure that we're able to report on how we're meeting national standards that have been set for us. So that's the plan going forward. Nigel, thank you.
Great, thanks, Phil. Thanks for outlining that. And yeah, we'll close this meeting now and just say thank you very much to all the presenters, and thank you for watching. And I hope you keep safe over the next few weeks and months, and we'll see you back again for our next public governing body in December. Thanks very much, everybody.